on the CTDSS YouTube channel. And Olivia, let me make sure you can share. Should be able to, hopefully.
Great. Yes.
Great. I think we have 12 folks, and we get started here in just 1 minute. And hopefully less technical issues than in our hybrid meeting at the last meeting. So. Well, we're at 3 or 2. I think we can get started, and I will turn it over to Guy just for some opening remarks. We just want to say welcome, and we'll be really chatting a lot today, and I'm so glad so many of you are here. Guy, let me turn to you.
Great. And Olivia, would you mind taking down the, if it's easy, would you mind taking down the slides just so we can see each other? Well, thanks. Really appreciate that. First of all, thank you all. Nice to see you. I really appreciated the in-person meeting that we had a couple of weeks ago. I don't know if others agree, but I felt like this group really came together. I think we made a lot of progress. I feel like I learned a lot from that discussion, and I just wanted to start by saying thank you. I know that's a big commitment, this whole process and including an in-person meeting, and I just want to say thank you for that. Looking forward to our next in-person meeting, I think in January. I wanted to build on that progress today. So at our last meeting, we helped identify real priorities, things that we think we can and should do better. For example, access. That was a theme that came up again and again in our discussions in the in-person meeting. That's really helpful. That's only the first step, right? It's one thing to say that access is a challenge and something we want to work on. It's another then to say, what do we mean by access? How do we measure it? And then eventually, how would we make sure that the financing model is supportive of that? So in today's meeting, I want to build on that progress from the in-person, and for 3 select priorities that we heard from you last time, access, chronic condition and targeted care management, and data and infrastructure, 1, 2, 3. We wanted to spend some time listening and talking about how one might measure or define those. Again, with the final step thinking, how would we have a payment model that supports that? So today we're going to walk through those 3 areas. We're going to try to focus on what do we mean by them. I'm guessing this is going to be a helpful discussion because I suspect when we say something like access, different people on this call may mean different things, and sometimes getting really clear on how we're going to measure helps to bring out those differences in what we mean. And I think that can be a really productive discussion. So I want to thank you in advance. I want people to be honest and open and have a really good discussion because today's meeting is important. That's all I wanted to say. It's back over to you, Brett.
Thanks, Guy. Appreciate that framing. And I'll just add, yes, definitely appreciate the in-person meeting. We're looking to schedule them to hopefully help bring us together and provide some time to discuss further issues. And I think it looks like January will be the next time frame for an in-person. I know that it probably won't for everyone. We'll work to make that a hybrid meeting as well, similar to last time. You'll also note that we really try to get this materials out ahead of time. So hopefully that try to be responsive to that request to give enough time to review. Just given that we did make some minor tweaks, so we'll have an updated set to send out and to share publicly. I don't think there's anything substantial. It's mostly how we're framing it and discussing, but for content, you'll see it's really unchanged from what we sent out last week. Olivia, you don't mind throwing back up there? We'll just run through the agenda, but I'm just in quick, obviously, opening remarks, which we're doing, kind of recapping goals for today, and then we'll be talking about those topics. Just of note, the data infrastructure and data sharing, realize if we don't get to that today, we're okay with that. Ideally, we will, and we'll try to, we can bring that back next time if needed. But we are trying to be a little more aggressive with getting through some of these topics, and we recognize that may not be feasible. So I think we can go on to the next slide and jump into a quick recap and process overview. I am just going to, I think, mostly read this because I think it's helpful just to hear, but feel free to read it. So it's during our last meeting, we got a lot of feedback, as Guy noted, on the things that primary care should be doing differently or better to improve member health and well-being. And we discussed whether we should be more prescriptive or flexible in defining what primary care should be doing. And so what do? We took that, and for today's meeting, as Guy teed up, we identified those priority areas, and we're talking about 3 of them, as we already said, and then proposed points of measurement and report and/or requirements for holding primary care practice accountable to achieving those goals. So you'll see that shortly. We'll review kind of what we're going to be talking about today and how we're trying to drive this conversation. I can go to the next slide. And so we're really focusing on some specific goals. We're really trying to get directional feedback from all of you, from the committee, on these particular domains. And so the answer to the questions like, are these the right goals? Are there other measures, requirements, or equity strategies we should be considering for each domain? So again, on accessibility, which we'll be talking about at the top. And then for this domain, can we rely primarily on measures? Are there any requirements that are particularly important? Just remembering that, there's a limited set of things that we may want to ask providers to be doing. The more we ask, the more challenging it can be for providers to focus. And so part of this conversation is, where do we focus? How do we prioritize that? And so we're looking for a lot of your feedback on how we think about going about this. And again, this is really on expectations. Today's focus on accessibility, where we talk about data infrastructure, it's really at the provider practice level. We'll have more discussion of the role DSS plays in developing infrastructure, payment incentive structure to support those at a future meeting. So again, really through the lens of what are we asking providers to do? We can go to the next slide. So this is just a reminder. These are the primary care capabilities that we asked you about and discussed at that last meeting. They're ranked in terms of got the most prioritization, and we're talking about those top 5 today. Again, chronic condition targeted care management, accessibility of care, health-related social needs screening and community supports, data infrastructure and data sharing, and team-based care. You'll see, and I think we elevated previously, that behavioral integration is a really important item. And we actually thought that for our purposes of this conversation moving forward, that could really fall under chronic condition and targeted care management for the purposes of kind of building out what we think about the goals and drive of that domain. So not to say those other ones are important. Again, recognize if we ask primary care to do everything, it's going to be very difficult for primary care providers to do all of those things. And so we do need to prioritize, and that's part of this work. Can go to the next slide. This is just some key feedback from the committee discussion that we were trying to summarize here. I will just read it through it. I think it's helpful to say it out loud. Ideally, we be prescriptive about outcomes and flexible at how practices achieve those outcomes. When reliable outcome measures are available, we can be more flexible. When they are not, we may rely on priority process measures or requirements. The level of prescription versus flexibility we want will likely vary by domain. There's a lot of variation amongst practices in terms of starting point. Consider how the program structure would give providers the flexibility and time to build out targeted capabilities. The capabilities practices are developing should be applicable across payers. We should avoid creating Medicaid-specific processes and use existing processes and requirements when possible, where possible. We need to be careful not to create barriers to access by putting more restrictions on providers. We also need to consider what implementation supports practices will need. So again, just trying to provide some of that key feedback that we heard. Go to the next slide. So this is a informed approach to having this conversation. Again, kind of going back to this last meeting where we asked you to rank domains. So we're discussing again 3 of them. We'll be starting again with accessibility. And so we want to at first kind of ground ourselves in a goal or the goals, and then review example measures and requirements that we can use to hold primary care providers accountable to achieving those goals. And also think about what is an embedded equity strategy for each of these mean. And then we'll discuss, are they the goals? Are there other measures, requirements, or strategy we want to consider? And then can we rely upon measures, and are there any requirements that are particularly important? So again, we'll tee this up, and then we'll have a conversation. We'll ask all of you to weigh in. So I think we can jump right in. So with that, again, I mentioned this before, but we're hoping to get out of this directional feedback on the goals, examples, and approach. And it's important that note that I think what we're not doing, we're not deciding on a final set of measures or requirements. They're examples really intended to provide some specificity to the discussion and give you something to react to. We're not suggesting that we would use all these measures or requirements, acknowledging we need to be thoughtful about how many measures and requirements we include overall. And then we're not finishing this work today. This discussion, again, is the starting point. We'll return to this in subsequent discussions. So with that, Mark, you want to jump in and ask a question? You're on mute still.
I'm sorry for the disruption. I didn't touch my keyboard or my mouse, and so I have no idea why my hand was raised.
No problem. Just wanted to hear your voice maybe to start this.
Thanks.
No problem. So I think we can jump into accessibility of care and say, again, one of the things that we took away, and you've heard the commissioner who's not able to join today, but is aware of what we're talking about, is can DSS ideally try to frame this, provide some specificity about accessibility of care, kind of goal, ideal state, best we can, and then provide some measurement and specificity. And so again, this is kind of how we landed on these. You'll see here, the goal is to ensure members have easy and timely access to care and address the range of barriers that make it challenging for members to access care. Again, we'll come back to this. We'll ask you to provide any feedback on this. Ideal state, this is from the OHS roadmap, Office of Health Strategy, that an ideal state care is easily accessible and prompt using multiple care modalities, including in-person, electronic, and virtual care, and virtual visits, and include time outside of traditional work hours. Care is accessible to persons with disabilities and is culturally and linguistically competent. So we'll come back to this. So on the next slide. So here, again, for framing, we're reviewing example measures, an equity strategy for measurement, and that's on the left. So on the left, you'll see this example measures. On the right are example requirements, so more specificity, things that we might require providers to do. We're starting on the left. And just to help you walk through it, we kind of frame this as, you'll see program and steward. The program is, especially who oversees this or uses this currently or recommends its use. The steward is who is responsible for updating this measure, usually nationally. And that's kind of where this stands for it. So for example, you'll see that child adolescent preventive care, that first one under process, is underneath, currently listed under OHS's aligned measure set. And so that's where you'll find that. It's a NCQA. That's the National Committee for Quality Assurance. That's who stewards it. That's a nonprofit organization that nationally tries to update it and oversee it on a regular basis. So just for giving some context for those who are less familiar with this terminology. And so with that, we'll just kind of walk through a little bit of some of these example options that we've listed. So again, and maybe I should just say for a process measure versus outcome, and sometimes you can debate which ones or which. Usually think about process measures are there to achieve outcomes, not typically the other way around. That's a high level framing. Or you can think about, in a process measure for healthcare, process measure focuses on the steps that should be followed to provide good care, versus outcome. An outcome measure that focuses on the health status of the patient resulting from the healthcare. So usually as a result of the process measure. And so the process measures we listed here are, some that are fairly common. Some of you that are familiar with process measurement will have seen these before. Child and adolescent preventive care, and then child and adolescent well care visits. Under child and adolescent well care visits, developmental screening in the first 3 years of life, immunizations in adolescents, well care visits in the first 30 months of life. And then we listed cancer screenings, breast cancer, cervical cancer, and colorectal cancer screening. For outcome measures, we included hospital utilization, including avoidable emergency department visits. This is currently used in PCMH Plus. In here, you'll see the measure is 3M. That's the organization that oversees it. Avoidable hospitalizations, and then ambulatory care ED visits. We also listed member experience. So PCMH, Person Centered Medical Home, CAPS, is a survey that is done. We use this currently and that's the Consumer Assessment of Healthcare Providers and Systems. They have various surveys, including for outpatient care. And the question did you receive enough information about what to do if you needed care during evenings, weekends, or holidays? Another general CAP survey is getting needed care quickly. And then there's a PCPCM survey, that's person-centered primary care measure. That's a question asked, my practice makes it easy for me to get care. And then for the equity strategy here, we thought we would suggest segmenting the measures by race, ethnicity, language, REL data, as well as IDD, so intellectual and developmental disabilities, as well as demographic information to help measure disparities. That's again on the measurement front. Let's switch over onto the right side here, where we're talking about example requirements. So there's some here from other states. They can be, PCMH is obviously in-state, but that's a same-day appointment requirement, telehealth capability, after hours or weekend sessions, or 24/7 access to a care team practitioner. And so you'll see here certain requirements for different programs. Some of these, again, are state level. Some of these are national. PCF is primary care first, and CPC is comprehensive primary care plus. And then underneath that, you'll see the equity strategy for example requirements in the purple. So those include competencies in care of individuals with disabilities. PCMH Plus includes that. National standards for culturally and linguistically appropriate services or class is also included under PCMH Plus as a program as of now. So we're going to now switch to having a conversation about what we just talked about. And so as a reminder, I already said the goals a few times in the questions, but I think we're going to do some live note taking. So thank you, Olivia, again for doing that. And so did we frame this goal correctly? Is this the right goal? These are right goals. Is this the ideal state? And then we'll talk about measurement requirements, equity strategy, and then can we rely primarily on measures? And are there any requirements that are particularly important? So does anyone want to quick react to this, again, on accessibility of care? Ellen.
There we go. It's a good list. I like it, especially like the avoidable ED and avoidable hospitalizations and the CAP survey. A couple of things that have come up in just in research, and maybe some of this might be about care management, but it's really for every patient. Making sure that there are calls or somebody's reaching out to people beforehand to make sure that they have a ride, remind them about the appointment, ask them if they have any special needs, especially for people with disabilities. And another question is, what are the wait times to get appointments? Not for a same day appointment, which I assume is for, when you're sick, but for something that you can plan ahead, but how long does it take, for instance, to get a well child visit? And also the wait times when you're in the office. How long do you wait there before you get in to see somebody? Flexibility in changing appointments as needed, because a lot of low-income workers do not own their schedules. And so they set an appointment a month ahead, and then they find out that week that, they can't make it at that time. Whether it's, I guess this is more of a question, not necessarily for the practice, but whether it's easy to find a primary care provider near you. It's a serious issue for accessibility and someone who can meet your needs, who has, language access, who has maybe access for whatever your disability is, someone you feel comfortable with.
Thanks, Alan. Go to Alice.
Sure. I was just looking at one of the data slides you had on unattributed members, which sort of goes to Ellen's last point. If we're defining access and trying to address access, wouldn't we have to first sort of look at who it doesn't have primary care? And how do you address that first, which I know is something DSS works a lot on. The other finding that we had when we did our CMMI innovation first round really was that the emergency department was a better solution for a lot of families who work multiple jobs. And it had two reasons. One is because it's open 24/7, and two is that they can leave with medicine, especially asthma as being one of the biggest drivers for an ED visit. And that they would get an asthma pump and be able to leave sort of whole, if you will, or ready to help their child. Thank you.
Thanks, Alice. David?
Just a couple of thoughts, and I may be jumping into the second bullet, so I apologize for that. I do have some concerns about the two outcome measures, avoidable emergency department visits and avoidable hospitalizations, especially since they're proprietary measures that don't provide information data during the year on how one is doing on the measure. We have to wait almost 11 or 12 months after the year's ended to know how we've done. So it doesn't help us in trying to address those patients who have had avoidable ED visits in real time. That's concerning to me. It also doesn't have national benchmarks that we can compare ourselves to because it's proprietary. It also doesn't have specifications that we can, detailed specifications that we can look into to understand what the inclusion and exclusion criteria are. I would strongly argue against having a proprietary measure in any of these, including PCMH plus, although I know we use that already. So that's one. I would consider something like readmissions to be included in hospital utilization. I think a 30-day all-cause readmission metric might be appropriate. There are some for adult and for pediatric that can be used. I think that's an important metric and something that's very important to control when thinking about controlling costs and outcomes. And then I'll wait to talk about some of the specific measures that I think we could include in the pediatric set. Thank you.
Thanks, David. CJ?
Yes, hi, thank you. I just want to echo what was already said. And also, in terms of communicating with people, what's happening is sometimes folks, their medications aren't being authorized. They're stuck in a limbo. I'm one of those people. I'm also asthmatic. I also know of quite a few folks who are walking around without insurance. So for what was just said, that's actually what I was going to say. I want to second that. I would like to know why people are going to the ER. Is it because you didn't get your stuff in on time? Like, what happened? Because part of the issue, as Ellen pointed out, is in trying to renew, a lot of people are working or have job hours at odd times and stuff. And it's kind of hard to get in touch with somebody. So just the whole communication piece. And then also too, with the current rent rates, some of us had to move around. So mail is being sent if we're dependent on letters. I don't see what's the point of collecting emails if we're just sending letters. But if we could do both, I think that's okay, because folks are moving around and probably don't even realize that their stuff is past due or anything like that. Thank you.
Thanks, CJ. Just a couple of quick notes. I think one of the things we'll have to balance here is having, again, more measures and more which ones are important. How do we think about, how do we hold which providers accountable? I don't know anyone to hold that, but obviously the more measures we have, the more challenging it can be to prioritize those. And so figuring out which ones are going to be most important. And also just point out that, as we were doing this, we try to think about some of the other feedback we've heard from providers is having different measures across different payers can make things very challenging as well to know where to focus. And so there is potentially opportunity to try to align when it makes sense. Obviously, recognizing there may be specific areas where the Medicaid population and our members need to focus on to really help drive change, but also knowing that there may be a lot of utility in trying to align across pairs, which is one of the strategies that was outlined earlier on. I'll just note, I think, CJ, your point about like some of the challenges about getting medications authorized, I know, curious to hear about some of the member experience pieces, which we use a little bit, and there may be some challenges with gathering member experience at the granular level of at each individual provider, but maybe an opportunity to measure satisfaction with certain things like getting access to care as well as access to medications. Mark, let me turn it over to you.
Thanks, Dr. Richards. I had one comment and one question, and the comment is that I agree with Ellen's suggestion that one of the things that should be considered is the empanelment rates, since I think 40% or so of the Husky adults are unimpaneled as a program-wide goal. And I understand this is not something you can apply at the practice level, but as a program-wide goal, trying to drive an improvement in empanelment suggests that as a population, Medicaid has a usual sort. Patients have a usual source of care for both prevention and illness management purposes. And so the reason I call that out, I don't think it's a good practice level measure. I do think that it would, as we think about companion initiatives that could involve system approaches in a region, it could be a very good measure of the extent to which a region is solving for the multiple issues that need to be solved for to ensure that people can get to a usual source of care that's not an emergency department or something like that. The question that I have is, for me, it's always been the most intuitive measures are mystery shopper, which is hard to do on at a practice level, and the CAHPS measures about the extent to which you got needed care timely, some of the ones you have up there. I'm wondering, based on either your review of the evidence today or your experience in PCMH Plus, whether you think those are the best, most direct measures of access. And I'm also curious as to, for my, the provider colleagues on the group, whether those are essential methods for measuring the experience of access for attributed populations.
Thanks, Mark. And maybe just quickly on the attributed, so just again to frame that, I know this has come up a few times, but those are folks who, Medicaid members who are not attributed or linked to a primary care provider, and depending on the age cohort, it varies quite a bit in terms of how many people are attributed or not. And we looked at that earlier this summer. I think, as you said, Mark, maybe something challenging to ask primary care providers to do, but it is something I think that DSS is very interested in doing. And it is something that we've been working with CHNCT to help try to orient towards, because there's a lot of reasons that as the Medicaid agency, we're interested in getting people in panel. We really want them to have providers. And so figuring out how do we encourage that? Obviously, we need to make it easy for people who need new primary care providers to have that. That comes back to access for new patients. And I think, but there may be some challenges with holding primary care providers accountable for that potentially. But I appreciate it. It is obviously really important. And I think it is something that we're very interested in trying to think through as well. Again, maybe more on the DSS side than on the primary care provider side.
So the other part of my question, Dr. Richards, was your experience with the CAHPS measures around needed care and whether you think that those are the best. Does the national evidence suggest that those are still among the best, most direct measures of experience of access?
I think mystery shopper is very helpful. As you know, I think, Mark, that is some data that is captured at a broad level. Maybe not. I think there's challenges with capturing that at each provider. It can be costly and difficult to do mystery shopper at that level. But just to say, CAHPS, I think, is a very reasonable survey that has a lot of data behind it. There's some, I think there's some opportunities to improve CAHPS, PCMH CAHPS, but at the same time, it's widely used. We still use it. We also use PCPCM. But I think it's a fair assessment. And I do think we are very interested, and we're curious to hear others' thoughts about trying to capture member feedback, if possible, at that granular level of detail for providers. It gets much more challenging when we get to, if you have a panel of 50, Medicaid members, it's harder to capture the data as significant enough and a big enough number to make it significant for a panel of 50 versus, a panel of 1,000 or 500. So just to say there's some challenges with implementation, but I think we are very interested in exploring how we can better capture member voice that might, that we can tie to access or other issues. Guy, anything you want to add to that?
No, I think you put it well, and I just want to recognize, I think Alice, you and Mark in this meeting and others in previous meetings have brought up the point about unattributed members or unimpaneled members, and that I think it's a good push. I think as Brad is suggesting, I would view that as something on the DSS side. So maybe when we go back and are thinking about the policy, maybe there'll be a set of things that on the payment reform side that we do, and then there's some things that are on the DSS side, like identifying in the data those high needs members who don't have a primary care doctor, having relevant messages to them to to try to make it more straightforward for them to find a primary care doctor. Anyway, I just want to recognize that, and I hear you on that one.
And I'll just add, I mentioned that CHNCT is actually doing this with identifying high risk, high needs members who don't have a PCP and trying to help do outreach. And that's kind of newer work that's been happening over the past year or so that they've been focusing on. And I think there's a good reason, as Guy said, for us to think about how do we make that more of a priority for us to help get people to primary care. Again, knowing that you need to have primary care providers willing to see new members is also important here. Any other questions or thoughts that folks want to add? And Polly, I think you had mentioned that comment. Do you want to add anything verbally to that? You noted there's other measures, I think, of ED utilization and that you all have looked at. Go ahead.
Yeah, and again, we would, the ability to get the claims data, to get the data ingested into our systems and use it on a timely basis. Also, a mean for us to calculate, based on people who are frequent utilizers of the emergency department. So, and again, a smaller practice may struggle to do some of what I just described, but others that have, other value-based arrangements may have the tools and the mechanisms to build those out.
Thank you. Ellen?
Yeah, I just noted that in the chat that Medicare has had avoidable ED and hospitalization measures for many years, and the ACOs and hospitals in Connecticut have been reporting it. So I don't know what the timeliness of it, to David's point, would be, but I think we should be looking at that, because if it's already in use, why not?
Thanks, Ellen. Any other, again, just going back to the questions that we asked, and just as a reminder, are these the right goals? Are there other measures? And I think some of you already responded to this, requirements and equity strategies you can consider. And then finally, and then Allison, we get to you, and then I'll remind folks of the last question.
Yeah, I was just, thinking about what DSS did with the enhanced care clinic for behavioral health, and really around timeliness of access for within the threshold of the next new appointment available. So, like if we were able to translate that into primary care, establishing, how much time they have, what's available for the next appointment, and that the person majority or 80% of the people are able to get into that time. I don't know if that is as easy to measure, but we've had to measure it through our behavioral health, so we have to treat, from the moment of call forward. So looking at that as a measurement might be helpful.
Thanks, Alice. Pauline?
Yeah, I mean, I also wanted to comment, some of the measures like, some of the cancer screenings, those are kind of like yes, I mean, they're very dependent on having that access. They also have other value, I think, in the program and, kind of having those kinds of measures and focusing on the preventive care. I think is both from an access standpoint, but also, wanting to ensure that there aren't, if we start to stratify those by the health equity indicators, trying to close some of those gaps, I think will also be important.
Thanks, Paul. I did want to pivot, I think, to that last question. Like for this domain, can we rely primarily on measures, or are there requirements that are particularly important here? Again, not saying that one and or the other, but that kind of directionality is important. Of note, I think there are a lot of measures that we've identified already that are probably ones that we could say are there outcome measures that we feel strongly could help drive this, because some of the things that have been said are more specific requirements, again, versus focusing on outcome measures. And I think, as we discussed last time, if we can focus on outcome measures, it lets potentially those solutions come because we're focusing on what the outcomes are, if we think they are strong enough. So Ellen, I see your hand up, and go ahead.
Yeah, I think we could expand the process measures. I mean, one of the ways of looking at whether people are getting care or not is looking at utilization. And you only have a few here listed. I think we could expand that.
Yeah, this is definitely not meant to be exhaustive. So just as examples, but appreciate that. Any other thoughts?
It's been a really good discussion. I know there's a lot written here and a lot of diverse views, but I also think it's helpful. I'm just going to say something to make sure I'm hearing you right. It feels like largely the goal and the ideal state, which we put in the chat, it feels like there's good alignment around that in terms of what we mean by access. And if I'm not hearing that right, let me know. But the fact that we haven't had any comments saying, hey, you missed something important in the ideal state makes me think that we have pretty good consensus around that. Is that right? Good. Okay, that's 1/10 of the battle, is agreeing what's the problem that we're trying to solve and what would the ideal state look like. So I want to just celebrate that as a win if we get consensus around that.
Yeah, and I think the only thing we heard a little bit about, maybe just to say, is like the unattributed population. Where
good call. Thank you, Brett. Yeah.
But I think acknowledging that maybe for this purposes that may be outside the scope of this work, acknowledging it's super, super important, and maybe it is something that we can take that back and think about as well. I think internally to see, like, is that something that's fits within this in some way? But appreciate the importance of it. I think we all agree that people need access so they can get the care they need, and getting people into primary care is an important part of that. With that, I think we may be able to move on to our next topic area, which is chronic condition and target care management. We're going to follow a very similar format. We have attempted to provide a goal and ideal state. There's measures and requirements, again, that we've outlined, again, not meant to be comprehensive for purpose of discussion. And then we have the same questions at the end. So hopefully this gets familiar. So the goal is improve chronic conditions prevention and management with a focus on reducing unnecessary inpatient ED utilization. Ideal state, coming from OHS, there's 2 items here listed on their core practice components. Is practices engaged and support patients in healthy living and in management of chronic conditions. And then care delivery follows evidence-based guidelines, prevention, health promotion, and chronic illness care supported by electronic health record clinical decision support. So I think we can go to the next slide. And so again, on the left, we'll see specific example measures. On the right is example requirements. And as you noted, we said program steward. So again, as mentioned before, asthma medication ratio, the program that it falls under the aligned measure set of OHS. It is stewarded again by NCQA, the organization that helps update it on a recurring basis. So, for example, of process measures, again, the asthma medication ratio, eye exam for patients with diabetes, kidney health evaluation for patients with diabetes, behavioral health screening and management. And just as a reminder, we had said we were including behavioral health integration, behavioral health underneath the chronic condition. So we included behavioral health measures here. Behavioral health screening and management, follow-up after emergency department visit, hospitalization for mental illness, screening for depression and follow-up plan, use of opioids at high doses, metabolic monitoring for children and adolescents on antipsychotics, substance use assessment, and primary care. Outcome measures we include hemoglobin A1C control for patients with diabetes, hemoglobin A1C port control, controlling high blood pressure, hospital utilization, avoidable emergency department visits, avoidable hospitalizations, member experience, again, back to the PCM survey. Over time, my practice helps me stay healthy. Chronic condition cost of care, which is a newer outcome model from Colorado's alternative payment model 2. The equity strategy would be similar in terms of segment measures by race, ethnicity, language, REL data, and IDB demographic information to measure disparities. And then on the right, going to potential example requirements, define a protocol to identify patients who may benefit from care management. PCMH is currently doing that. Complete specific activities to advance behavioral health, physical integration, health integration. PCMH Plus currently has this listed. Deliver individual self-management support services for chronic conditions, emphasis on hypertension and diabetes. MCP, which is the new Making Care Primary model from CMMI. And then underneath that, for equity strategies, cultural competency training for chronic conditions management team. So we'll go to the next slide where we're going to have, again, a similar discussion about are these the right goals, measures, requirements, or equity strategies that we should consider. And then for this domain, can we rely upon measures and are there any requirements? So Ellen, go ahead.
Yeah, I have actually quite a few here. I would like a survey that asks people whether they're getting better. If they feel that they know the name of their care manager would be a good question. And can they get to them and they know how to get to them? Do they know the patient? Non-medical supports, nutrition, smoking cessation, things like that. And a big piece of this is care plans for people with chronic conditions, knowing what the plan is to get them healthier and what the practice is going to provide them and what their responsibility is in response. We did a lot of work in this. It was a 2018, but best practice recommendations in the care management committee, the chronic condition committee of MAPOC around best practices for care plans. And it's several pages, but making it patient-centered, making sure people have seen it, that they participate. It's not something that spits out of an EMR, and that they've signed off on it, and that it's updated on a regular basis. We have, there's a lot in it, in clear communications and just making sure that everything is clear and that it's available to caregivers at with permission from the patient. I'm a big fan of care plans.
Do you want to jump in?
Yeah. And Brad, I want to apologize because you and I talked about these slides a lot before, but sometimes seeing it with fresh eyes and hearing feedback causes me to at least lightly challenge what we put as a goal. So we put as a goal improve chronic condition prevention management with a focus on reducing unnecessary inpatient and ED utilization. First of all, I think this is a great goal, and I love that we have both prevention and management. The thing I wanted to at least test a little bit was the inpatient and ED. I know those are important outcomes, but for example, diabetes, helping manage someone who has diabetes, well-managed diabetics will have lower spending, not only on the inpatient ED side, but also in the medium run and the outpatient side as well. So I'm wondering maybe if we want to broaden the goals slightly to think about like total resource utilization or unnecessary, like a foot exam. I mean, I know I'm rambling a little bit, but I just want us at least to think about things beyond ED and inpatient for consideration. There may be good reasons not to, but just wanted to suggest that we think about that.
Thank you. Mark, I see you unmuted. Do you want to chime in?
Yeah, just actually I think Guy's point is a good one. I think what's missing here is sort of a patient-centered or person-centered goal, which is to, the goal of better managing hypertension is to reduce long-term cardiovascular risk and the inequities associated with that, like the extraordinarily high cardiovascular deaths among Blacks versus whites in Connecticut. So it seems to me that the goal of chronic condition management should be controlling the chronic conditions to achieve, sort of optimal management for the patient. It's a secondary consequence that in our view, and I know this isn't traditional payer view, that you use the hospital less foremost. I think is the patient better? And are they at reduced risk of retinopathy and nephropathy and all the other unhappy things that happen when you have poorly controlled diabetes, for example?
Thanks, Mark. I would just say, I think that makes, I think aligned also a little bit with Ellen. One of the things that you said was, do people feel like they're getting better? And I think maybe recentering that goal slightly around, we obviously want to see prevention and management improvement aligned with the goals of those individuals. And so I think that's a very fair consideration for us to think about. Ellen, I did want to circle a little bit back to a few things that you pointed out that I think generally agree with on, making sure people are getting care plans, that people feel like they're getting better. One of the, I think, things that we have to think about, and I welcome your thoughts on, is doing that in a way that is, how do we do that in a validated way, that in a way that we can measure? Because obviously we can ask providers, or we can ask people whatever their experience was, but I don't know if there's any specific tools that you would point to outside of CAHPS or others that you think could be helpful, or if you're kind of suggesting we should just be asking, we should be making up questions and asking members those questions.
I think we can look at, their clinical conditions, but I'm a big fan of asking them, do you feel better? Are there things you can do now that you couldn't do before? There are good questions to get at that. I also, I think the care plans, when I know I'm I'm just honed in on this, but it's just a way to look at whether people actually got the things that were there, they met the goals that are in the care plan, whether they did what they were supposed to do. But it's very individualized. It's not, one size fits all.
Excellent. Yeah, I think there are probably, if there's validated measures, those are important. I think, again, we have to figure out a little bit, what some of the decision will be like, how much of this is Medicaid specific versus when are there opportunities to utilize measures that may be used across payers, understanding that, I agree, Ellen, care plans need to be individualized. It doesn't always make sense for someone to have a blood pressure of, maybe 120 over less than that. It might be fine that it's within their goal that their blood pressure is actually 150 over 100, and that's better than it was before, and we're okay with that. But their hypertension isn't controlled, but that's within their care plan. And I think obviously allowing for that type of individual flexibility is really important, because it should be the person's choice as to what care they're getting and what their goals are. Alex?
Seems to be a cycle of those of us speaking. I'm sorry. I just wanted to kind of touch on the targeted care management a little bit. it's interesting to me. I have a daughter who was hospitalized for really high diabetes concern, and she probably spoke to maybe 4 different care managers during the hospitalization and after. But no one really was able to reach her in the way that she needed to be reached around her youth, and having someone to count on to ask about her lifestyle and things that she was doing. And so I feel like when we're talking about targeted care management, we're not talking about office-based or phone-based or even hospital bedside-based care, but really engaging and understanding the needs of the particular individual that include both the chronic stress that they may be exposed to, the issues related to poverty or food food insufficiencies and healthy food, and that we should really think about, I guess, Mark, you said something like thinking about the whole person-centered goal. We have to really look at what are the barriers for the individual being compliant. And when you're 18 and you're non-compliant, you can kind of recover and kind of move on until you're pregnant at 25, and then it becomes more of an issue. So I just am curious and interested in where targeted care management and what that would mean within a primary care setting.
Thanks, Alice. Yeah, I think there could be more specificity, and it probably depends a little bit on what we emphasize potentially on even measurement or around certain chronic diseases in terms of if we're focusing on hypertension or diabetes or any of those, what are the things that we try to incentivize providers to focus on? But I think it's a great point. At some point, to provide some more specificity on it. CJ?
Yeah, sorry. I just want to echo what's being said about the, one size doesn't fit all. And I hope that is also applicable to the disabled and elderly. We already have issues with access in terms of reaching someone. So I hope, in terms of care management, that is considered as well. Because on another note, sometimes those who are providing the care management may not realize, this person has a disability or they're a little older, so we need to care a little more. Thank you.
Thanks, CJ. And I think one of the things that you bring up, and I think a little bit on the equity strategy is trying to segment by intellectual and developmental disabilities to a degree in terms of what data we have access to, but thinking about broadly, how do we make sure we think about breaking things down by demographics. And some of the things that we discussed in outcome measures, or even like measuring that for each individual person. And then could you say, well, do I have access to care? Or in this case, it's more of like, am I getting individualized care plan, or does the practice help me stay healthy? And I think that's an opportunity for us to try to get that at the provider level, but then break it down even more broadly by some of these diagnoses. So for example, diagnosis of various disabilities, to know, like, is this a problem for us collectively? So I do think there's opportunity in doing a better job of identifying these concerns, and appreciate that call out. Stephanie, did you want to chime in by any chance? I saw you put something in the chat. We would love to hear from you.
Hi, good afternoon, everyone. I'm sorry, I was just kind of piggybacking on what Alice said, because I am in 100% agreement with her. And I'm thinking that, as folks, as providers are engaging the patient in a more, meaningful way, ideally, that a way to see it happening in real time, so that, the next time there's a visit, there could be some level of improvement, some measure of improvement, is to engage community health workers, and not just community health workers who are necessarily tethered to a particular healthcare system, because sometimes people just need to be able to be community health workers on their own, and they're trusted and all that kind of stuff. So I just feel like there's a marriage of the two of those things that could happen that would improve the health outcomes and ultimately, you know, be reducing the cost, which is all the things that we're looking for. Thank you.
Thanks, Stephanie. And just want to say we are going to talk about care teams, and a lot of things that you're bringing up. I think there's a lot of connections to these other topic areas, and obviously these things don't happen in isolation. And it's not, you know, we can't rely upon just the primary care provider. I mean, I've been a primary care provider, provided primary care. Like, it needs to be more than one individual that's doing this. It needs, if we want to do this thoughtfully. And I think, you know, obviously when we talk about care teams and what does that broader primary care infrastructure care team look like, that's definitely part of the conversation about what is the role of a community health worker potentially that could help someone manage diabetes potentially, or hypertension, or a number of various issues, including health-related social needs. So just to say thank you for calling that out. CJ, did you, your hand's up? I'm not sure if it's a legacy. If
Oh, I'm sorry, no.
But no problem. Maybe I'll push us to the last question. I think haven't got to that one as much on this one. For this domain, can we rely primarily on measures? Are there requirements that are particularly important? I know this has come up a little bit, but just want to address that specifically.
And Brad, let me chime in as well. One of the things I struggle, I think about here, and really would welcome the input from this group on, is if we go back to the goal, I very much agree with, I think it was Mark who framed it, maybe Polly, on the goal here should be ultimately getting people better, like or stabilizing or like improving people's health, which is, you know, outcomes measure. Sometimes that's hard to measure in our claims data, or there are issues of risk adjustment. And so we kind of move toward the more process measures, but ultimately our goal squarely needs to be, I think, on keeping people as healthy as possible. And one of the things that I just think about is, under what circumstances are we comfortable trying to measure more directly the thing we care about, which is always my first, like, if you can measure it and it's reliable, you want to do that, or do we need to go back and think about more process measures? And I know we're not going to settle that question here, but just, I think in your responses, that's a place that we particularly welcome your input on this one.
Ellen, go ahead.
Yeah, I think you're looking for specific things that, like HEDIS measures, and I'm hearing more that, like, it might be people have their own goals for it. If you measure, for instance, Alice was just talking about mental health. Do people, are they lower on a depression scale? Well, that's not as important as somebody whose goal is to be able to walk without a walker. It's just going to be a lot more individualized. And I think we have to be okay with that. We need some way to collect that, but we need to understand that no matter if you pick broad numbers, blood pressure or whatever, you're going to miss an awful lot of people's goals. Care management is retail.
Thanks, Ellen. I'll just say, I think one way potentially of trying to get to some of this, because I agree, care management, a lot of this is should be at the individual level. We have to address individual needs. Are there patient-reported experience or outcome measures that we think drive to this point close enough that we can gather at a level that's close enough to providers to hold providers accountable, and then emphasize that. So just throwing that out, there's something to consider as we're thinking about both the need to wanting to improve health, but improving it for individuals is individualized. And the challenge with trying to reduce A1Cs across the board probably makes sense, but for some individuals, an A1C goal of 7.5 or even 8 will make sense. That's a number that may not be a goal for other individuals, or broadly speaking, but could make sense in the context of that individual. Or maybe they don't even measure A1C because it's as you're approaching end of life or things of that nature. So just to say, appreciate that consideration and something to consider in terms of how we're measuring this. CJ?
Yes, well, we're appreciating everything. I just want to echo what Ellen was just saying, because I'm afraid if we put things, and Alice mentioned this too, we don't want to make the basket too broad. That's how we got here. And especially with the mental health aspect, I don't know about you, but there's a lot of stressed out people out there. So I think we really need to consider that and hear what the providers are saying. Our community health workers matter, and we need to make sure that they're well equipped to do what they need to do. Thank you.
Thanks, CJ. Angela?
Good afternoon. I just dropped in the chat an additional perhaps measurement of the connection to additional care and resources to deal with the whole patient. So even though they may come in for one situation, seize in that moment and that connection point to connect them to other resources and services might be a great way to measure the effectiveness of the overall system.
Thanks, Angela. Any other considerations or thoughts folks want to add?
This is Alice, just real quick. In behavioral health, we have a lot of these kinds of assessments that are asking about the whole child or the whole family. We're piloting through the Inc. now in New Haven, this needs conversation that's sort of topping the electronic tiering that's happening so that we can have one-on-one conversations with families around individual clients. God knows we don't need any more paperwork for anyone to fill out or questions, but there are a lot of documents that are already created that maybe could be looked at or utilized that are in behavioral health or in care coordination to be able to, quickly assess the holistic nature of the needs of the individual.
Thanks, Alice. Yeah, if you want to send anything, please feel free to send it along. Again, I think one of our challenges is going to be like, how do we measure and monitor it for some of this? And is this something we can do at a statewide level? And how do I think about it? But I think we should be considering all things at this point. So appreciate it. Mark, let me pass it to you.
Thanks, Dr. Richards. We've convened a number of the physicians and other practitioners representing our hospital medical groups. And one of the resounding messages from our most recent meeting was to focus on the provider burnout challenge, which hasn't been so prominent in previous discussions, and I think relates directly to the both access and quality measure discussion, which is that in general, CMS has moved from more measures to fewer measures with an idea of being more focused and reducing unnecessary burden on practices. And looking back to our opening conversation about accessibility foremost depends on having an invigorated primary care workforce, and we are seeing a lot of departures from primary care. And so one of the most important things I think I suggest we keep in mind is having a modest set of measures that are highly specific to what it is we're trying to work on, and ensuring that and having as a sort of consideration the extent to which they're going to add burden to practices. My other recommendation is that we not stand up measures that are not fully validated for the purpose. As near as I can tell, the avoidable use measures in emergency departments have never been a measure that's been used by CMS in the ACO program, the longest running and largest primary care accountability program. And while there have been advances made on those measures, and they could be suitable for reporting purposes in the near term, I think that due regard should be paid to Dr. Kroll's comments that that they may not be ready for use as a means to reliably assess practitioner or practice performance, which isn't to say it shouldn't be reported and examined, but to be to be cautious about implementing a measure for performance and payment purposes if it's not fully validated. So thanks.
Thanks, Mark. CJ?
I disagree with that because that's why we're here. We don't challenge GSU, we don't face it. We say, let's just be modest about it and hope it works. I'm not the only one saying this, so I hope that other people agree. And I'm pretty sure there are validated ways, as pointed out, so let's not create a barrier that doesn't need to exist. When folks go into DSS, they have to provide this information, right? It should not be hard because the funding is being received. I mean, how are we going to make this work if we don't think on this level? I'm just really confused with that. Thank you.
CJ, David, I saw your comment. Do you want to add anything or elaborate on that?
No, just to piggyback on what Mark was saying, I think a manageable number of measures is important, considering the work that would need to be done to improve on those measures. But I also think there has to be alignment across payers. If you have a small number of measures for one payer, a different set of small number of measures for another, a different for another, it adds up to a heck of a lot of measures and thus a heck of a lot of work for a primary care practice that's trying to do what it can for its patients. Thanks.
Thank you, sir. I think definitely that's an important consideration in terms of especially being parsimonious and having alignment. And this will be a tension point of trying to make sure measures are specific for the Medicaid population and making sure we're capturing and trying to really push providers to provide person-centered care, but also making sure we think about how do we align to make sure we don't have a list of 1,000 measures that make it impossible for providers to focus. And so that's definitely part of the balance. Ellen?
Yeah, I guess, I'm hearing a lot about, providers and they're important. But I agree with CJ. This is the reason we're here, is so that people are getting the right care in the right place. And, if you're in the ED for asthma or for something like that, there's something else going on and we need to look at that. And it's not saying that never happens, that's there are levels at which it just happens. But when that happens an awful lot to a particular provider, we need to look at that. And I understand why that's, difficult for providers, but that is the reason we're doing this. This very specific, narrow process measures are not going to get us to where people feel they have access. I feel very strongly about that and care plans, apparently.
Thanks, Ellen. Any other thoughts folks want to share on this? Appreciate the Angela, please go ahead.
Put it in the chat, but before we move on, I think to put a measurement on the effectiveness of each visit, to actually go against the trend, to deal with one matter, one visit, while you have the person in your presence, if they have co-occurring conditions, and issues, it should be dealt with while they're there instead of having to reschedule them for another visit, which could take weeks and weeks when you could already have been dealing with the matter at hand. I think that's a trend that's based on how folks are paid, and we should be intentional about addressing that head on. It's the elephant in the room, and it's driving up costs and inefficiencies and lack of quality care. So.
Thanks, Angela. Just say we are planning talking about payment in the future, so will be something that does come up. CJ.
Yes, I know we're going to talk about payment in the future, but that's affecting us right now. And what's also happening, to go off of her point, thank you for that, because it's also pushing the smaller providers out of the room. And then after that, only certain people get to be at the decision-making table, right? So it is the elephant in the room. Let's follow the money, right? I agree with what was just said. When the person's there, why aren't we asking the question? Because here's what's going to happen. When they go, let's say they leave the ER and they go to another agency to get their post-care, they're going to need to know what happened over there anyway. So what are we doing? That's all I really want to know. What are we doing?
Thanks, CJ. And I think this one thing I'll just note is, obviously, as we start talking about like what are the focus areas of the care focus areas, and how do we measure and think about that, and then that's part of thinking about moving to incentives and how do we incentivize specific behaviors that we think are really important for providers to focus on. So that will be part of starting that conversation in January, but appreciate the importance of wanting to address members' needs when they're seen and trying to address as many as possible. And I think that is important, and I think we appreciate that. So thank you. There's going to be tensions in some of this in terms of how we navigate putting certain priorities on certain areas in terms of specific measures. How do we think about capturing member input on the care they're receiving? And I think that is definitely an area we're very interested in, acknowledging some of the challenges with doing that at scale, but the potential opportunity that could raise. Any other things that folks want to add? I think we can move on to our last topic, data infrastructure and data sharing. Again, remember, this is really talking about the provider level. We acknowledge on the DSS side that this is something that we have to talk about on the DSS side as well, that from the provider focus, the primary care provider focus, the goal is develop the data infrastructure and data sharing protocols to support performance measurement and program monitoring, enable practices to make progress in addressing identified opportunities. Ideal state, the practice team utilizes patient information in conjunction with data from an EHR when utilized by the practice HIE, that's Health Information Exchange, pharmacies and payers to identify patient care needs, monitor change over time, and inform targeted quality and equity improvement activity, including design and implementation of quality improvement plans. Again, that's borrowed from the OHS primary care functions. I think we can go on to the next slide. And again, on the left are example measures, on the right, example requirements. In this, we have one process measure, which is participation in the alerting exchange system. That's either a pass or fail. And this is similar to like an ADT system for those who are familiar, alerting someone when they're in the emergency room in the hospital. The equity strategy would be, again, a potentially a pay for reporting structure here, where you get member level, race, ethnicity, language, and IDD demographic information. And then under example requirements, there's a lot more requirements in this space, again, at the provider level. So requiring a certified EHR system, the practice uses certified electronic health record technology, sharing clinical information. So clinical information is shared with hospitals and emergency departments. Both of those are in PCMH. This one's designate and agree to use a single EMR or utilize interoperable arrangements to enable seamless sharing of health information for efficiency and improved quality of member care. The PCMH Plus members' medical record and electronic health information must be accessible to all care coordination team members for care coordination purposes. So PCMH Plus, this is the next one, is participate in state health information exchange. It's the main PCP Plus. And then another one for main PCP Plus is health information exchange connection includes data elements that support clinical quality measurement. And the equity strategy under example requirements, again, as an example, would be implement a process for collecting and reporting the member level REL and IDD demographic information. And we'll go on to the same set of questions that we did for this. So are these the right goals? Are there other measures, requirements, or equity strategies that we should consider? And then rely on preliminary measures and any requirements. So Ellen, jump in.
Yeah, taking a patient-centered position on this, I think you should be looking at privacy. Are people choosing, they have a right to opt out of the state information exchange? Do they know that? People know what's in their records, they have access to what's in their records, the costs of doing that, and that the privacy policy should be clearly displayed in the office and on the web and in patient notices. And do people know how to access their records and how to correct mistakes in the record? The patient portal, how accessible is that?
Thank you, Ellen. Do you know just of any measurement tool that's being used in this manner? I don't think I've seen any, but you may have.
Measures about this, it'd be a requirement, I think.
Understood. Other input, thoughts?
Brad, under the health equity measures, was the intent to include SDOH data sharing as part of the equity measure set, or is that going to be captured on the quality data set?
We'll welcome your input on that. So let us know what are your thoughts?
I mean, I think we've spoken about the importance of capturing that data and being able to use that to identify individuals who could benefit, whether it be from a CHW program or understanding barriers to care or inclusion in their chronic care management programs. And I think, organizations are still developing the best ways to collect the data and to share the data. So we spoke last meeting about the glide path. And again, to me, this is one of those kind of fundamental data sets we might all need to agree to collect and to share and to figure out the most efficient way to do that.
And just any suggestion on a requirement or potentially or I'm assuming there's a requirement as opposed to a measure.
Say that again, Brad.
Sorry, just so saying, assuming what you're suggesting would probably be a requirement as opposed to a measurement process piece.
A requirement to capture it, yes, to screen the population and to share the data.
Understood. And some of this may come up in our health-related social needs screening discussion, but I appreciate that there's overlap in the data. So thank you very much. Ellen?
Yeah, this gets into areas of really serious privacy concerns, things like DCF involvement, criminal justice. This would you'd have to have some really good guardrails around this, and patients should absolutely have the right to remove things from the record, from things that are shared. They should understand what's being shared, who's being shared with, and have the right to take it out.
Thanks, Alan. Other thoughts or considerations here? Tiffany, I saw you pop off mute. I'm not sure if that is.
Yeah, I apologize. I'm suffering from a bad upper respiratory. I just wanted to get a little bit more insight on the privacy concerns. When we mentioned that this could involve ECF and other agencies, I just want a little bit more insight. My concern is that if we don't collect the right data, then we won't understand the right problems that we need to solve, especially collecting by race, ethnicity, and language data. So I just want a little bit more insight into the concerns.
Thanks, Tiffany. And just to say thank you for joining, and hope you feel better very shortly. Ellen, I don't know if you want to comment on that.
I worry about, people knowing that DCF is involved or that criminal justice is involved or that there's a domestic violence issue. Being in a record that could be seen by other people might, it might keep people from trying to get care. It might be a disincentive if people knew that that was in their record and it was being shared. And it could be used against somebody eventually, in a legal proceeding. That scares me.
Mark?
Thanks. Sorry for the delay. I just wanted to comment on the slide 15, designate and agree to use of a single EMR or utilize interoperable arrangements to enable seamless sharing of health information for efficiency and improved quality of member care. I'm not sure how much this tracks with the previous PCMH Plus requirement, which originally did not have a single EMR requirement and then introduced one 3 years into the program, resulting in a couple of hospital medical groups dropping out. We had a variety of organizations over years have built shared infrastructure in order to be able to aggregate patients for the purpose of accountable contracting. And in the case of hospital medical groups, they may be using different electronic medical records, but they also may share an infrastructure around data analytics and around quality management, performance measurement, and that sort of thing. So the one thing I would request in this case is to consider, carefully consider what utilizing interoperable arrangements means. And our preference would be to not create a barrier to hospital systems that are on different medical records, but coordinate around shared infrastructure to drive performance on quality and cost, that not preclude their participation.
Thanks, Mark. Any additional input on this? And obviously, we did not provide a lot of measures here, and I think tilts very much towards requirements given that, but welcome others' perspective given how we have framed this up.
Brad, it's key. Just one quick. Oh, sorry, I should have raised my hand. I jumped in. One quick thought, which is not related to this slide, but I just want to signal for this group. I think there's a separate question of, separate from what's on the slide, there's a separate question of if DSS moves forward, or if we together move forward with a reform effort here, what data can we, the state, provide practices to set them up for success in whatever model we go towards? And I think that's really important. That's separate from the question here, and it's just out of scope for today's discussion, but I just want to flag that that's very much on my radar. It's very much on Brad's as well. And I think the reason that we're not having that discussion now is I think that's downstream. I think let's think about where do we want to go, and then we'll think about how does DSS support providers in getting there. I didn't want people to leave this meeting thinking that when we talk about data, we only mean data that providers need to integrate or just like that. I think there's a separate discussion of what DSS needs to do as well. So
thanks, Guy. Yeah, very important, I think, to echo that we definitely need to have that conversation as well. Is how we can support practices on the DSS side with enabling these care functions and what we've discussed today. CJ, go ahead.
Yes, and I think if folks could just look at the comment in the chat, because I think it's also important to talk about who has access to that data. It's not fair if some folks have access and others do not. How are they able to provide the same level or even attempt to quality of care if the odds are already against them? Thank you.
Thanks, CJ. Angela?
Yes, I dropped in the chat that there seems to be a trend towards doctors using isolated systems and that to log into multiple databases to see their information. When logging into one system was originally a challenge. I'm not sure how or should that be streamlined, but it's an issue that's worth investigating.
Thanks, Angela. I think given we're close to 4:30, I want to make sure we end on time. So I think we'll go to our next step slide and wrap us up for the day. Just want to thank all of you for a very productive conversation. And I think it's really helpful to hear your perspectives on this and sometimes opposing perspectives, but which we appreciate. So today we talked about those 3 primary care capabilities and measurement. December 7th is a virtual meeting. We're planning on to discuss the other 2 as well. And if we have any follow-up from today's meeting, we'll make sure to bring that to you. And then we're planning on having an in-person meeting on payment models in January, which we'll be working on content for. So again, this was, I think, a very helpful meeting, and we welcome your feedback on any additional thoughts you might have after this. If you wake up in the middle of the night, please feel free to jot those down and send them to us. We do welcome it. Again, what the considerations here are: how do we measure this? How do we make sure we're making sure providers can actually focus on it, incentivizing the providers to focus on the areas that are important, and make sure that we're not that we're measuring the right things. I think there's that balance between making sure we're getting the right, asking the right questions, and then measuring the right outcomes if we can, versus making sure that we're trying to align with other providers at times as well. So there will be some balance and further discussion needed to iron out some of this in the future. Pete, anything else you wanted to add before we close today?
No, I think the only thing I'll say is just thanks again. Today's discussion was super productive. I am shocked in a good way that we got through all 3 topics, and I want to build on that success, and you've given us a lot to think about. So thank you. I really appreciate the input.
Agreed. Thank you all. And
are we going to get a copy of these minutes or these notes? Yeah. Thanks.
Yeah, we'll send them out similar to after our last one. And then we'll also send out these slides are very similar to what you have, but you'll see there was a few slight adjustments. We'll make sure those are you also have copies of this as well. All right. Thank you all. Have a good one. We'll see you in a few weeks. Hope everyone is able to enjoy Thanksgiving if you're not working. So thank you.
Thank you.